Right, so cranial nerves are very important, and there's 12 of them. So important foundational concepts are when you do it and check the exam, remember that part of checking for abnormal is what people are very focused on, but the normalcy is as important. So when looking at normal findings, allow that be accounted for as part of your reflection. Two is that thinking about where do they exit and how they travel to their destination, think about that because that will tell you where you might be localizing. We're always thinking about localization, localization, localization. The neuro exam is like real estate, location, location, location. Three, that there are, each cranial nerve has aspects of either being afferent, afferent sensory, efferent motor. So afferent means bringing input of sensation to the brain, or efferent, sending inputs down for motor or muscle control, or mixture of afferent and efferent. And then fourth, that the nerves are bilateral, that they're giving stimulation of both sides. You have the benefit of symmetry and mirror for comparison of your neuro exam. The one cranial nerve that's interesting is the vagal nerve, vagus nerve, which means wander or vagrant as it leaves the skull. It's going to be traveling all the way down through your thorax, your abdomen, downward, and have many functions. But when we do the cranial nerve exam, we're really just focusing a lot of this area of the swallowing gag apparatus. And then probably the last concept is that the neuro exam has a beauty of giving you some very key findings for localization, but these nerves often do more for function than we may really be utilizing for localization aspects. So cranial nerve 1 is olfactory. It actually exits from the cerebrum, is smell. And we'll check that often using like coffee, which is a universal smell the world people recognize. Cranial nerve 2 is optic, which is vision, visual input. Afferent, like olfactory, is afferent. And again, we test vision, we'll do visual pathways, and that is so important. But also it's interesting for optic is that because it is going to the visual pathways to the occiput, we're also getting some aspects of cerebrum function also. Then we're going to dip down, we bundle 3, 4, and 6. We're dipping down to the midbrain and pons, brainstem structures. But remember, they're going to traverse up back to the orbit where they do efferent innervation, motor innervation to move the eyes. But remember, cranial nerve 3 has autonomic and innervation to the eye for pupillary activity, lens accommodation, and does do motor elevation to the lid. So some unique aspects of 3. So 3, 4, and 6 we bundle together for eye movements. And when you do cranial nerve 3, remember that you want to be not too close to the patient, at least 10, 12 inches away, because you're too close. Just like when you check for pupillary, you don't want to get accommodation, and that will throw off your ability to use to get good vision, good motility testing. So very important concepts. We'll go through good motility testing. And then when you check for motility for patients with double vision, you can almost figure out by asking some key questions. If someone's double vision, do you see doubles? Not blurry vision, but do you see 2? If it doesn't go away, if you cover your eyes, that tells you it's a brain issue and not an orbit issue / ocular. And if you do see doubles, if it's worse or more double close, it's usually a third nerve problem. If it's worse far away, that tells you it's a horizontal gaze center problem in the brainstem, pons, brainstem area, or a 6th nerve problem. If it's more of a double vision in terms of looking further away, it's lateral gaze area. You can tell if it's to the right, it's a 6th nerve or lateral gaze center problem in that direction, or left, vice versa. So you can actually tell a lot just by asking simple questions with double vision. Remember, 6th nerve is the false localizing because the longest cranial nerve and traverses up. The elevated intracranial hypertension, elevated ICP can give false localizing due to the traction of 6th nerve. Then we get to 5th cranial nerve, which is the trigeminal, which means 3 branches. It has motor, efferent, and afferent, does sensation, to the tongue and also trigeminal, V1, V2, V3. So very important branches, and masseter, biting down. So we now that's in through the brainstem, pons area, many layers through the brainstem, the trigeminal nucleus traverses. But we really have a very reductive, reduced approach how we look at the trigeminal. Cranial nerve 7 has many aspects of lacrimation, salivary production, but really, and also does hyperacusis or dampening sounds in the ear. And we might do more of a detailed evaluation for Bell's palsy or lower motor neuron 7. But for an exam, we're really focusing often on motor. It does do taste on anterior part of the tongue, but we really focus on furrows of the forehead, closure of the eyes. Can they resist? Grimace, not smile, because smile is more automatic and people can compensate. Smile, closure of the mouth, puffing the cheeks, and how the nasolabial folds do they equally rise that level. So that's through the pontomedullary area. 8 is auditory or vestibulocochlear. Can they hear sounds? Can they hear sounds or numbers? And also it's a clinical experience because people often have vertigo, and you're going to be using other parts of the exam called the Hintz exam or other maneuvers to that level. And you might also see those patients nystagmus, which you might see in different eye motility aspects, nystagmus. Cranial nerve 9 is glossopharyngeal, which the name tells you what it's doing, which is giving a lot of sensory input to throat, posterior tongue, sensory, and swallow. So they're going to look at palate elevation and sensory input to the throat. That's in the medullary area. 10 is, we said, vagus, does many functions below, which is autonomic, but we're going to look at gag reflex. And then 11 is going to be lower medullary, and then it gets into some of the cervical exit points, spinal accessory, which is raise the shoulder, and then sternocleidomastoid. So checking your my right sternocleidomastoid, push contralateral hand, so this way. So you're going to have a person push your left hand on the left cheek and turn away. So it's always contralateral turning away. Feel the muscle and see how it moves. And then 12 is hypoglossal medullary. The name hypoglossal tells you what it is. Glossal's tongue and under tongue. Tongue move out, side to side, and push against the cheek, and then have the tongue rest gently in the mouth, the best a patient can do, and check for articulations. These are important points to the cranial nerve exam, and now I'm going to demonstrate the exam. We're going to get started here for cranial nerve. I'm going to close your eyes and tell me what this smells like. Coffee. Perfect. That's cranial nerve 1. And we're going to actually take your glasses off. And I'm going to do your pupillary. So swing below, not across. And has good pupillary responses. It was like good light for people with dark eyes. Perfect. That's great. For equal, they were 4 2 millimeters. Response to light equally. So we're going to check now. Have me look straight at my fingers. Move your eyes to the side. I'm at 8 to 10 inches away. Look up. Making sort of a cross, and then to the side, and then make an H. Good. And you see the speed that I'm doing? This is a good speed. You don't want to go too quickly that way. You could do some nystagmus now. Testing, see that nystagmus. It has some dizziness. Perfect. Good. And look at up gaze, which is always important for a lot of extrapyramidal disorders or neurodegenerative disorders. Perfect. You put your glasses back on. That's great. Extra. So we just did 1, 2, 3, 4, and 6. And now I'm going to have you cover your right hand over your right eye and just look at my fingers. We're not going to have to do math, because that gets more cognitive. So just look at my face here. And how many fingers? 2. Don't move your eyes. How many fingers?
2, 1.
Now switch hands, switch eyes.
2, 1, 1, 2, 1.
Now good. Now switch hands again. Another way you can do this is just point to the finger it's moving. A little tricky for you now. Switch in hands, switch eyes. Good. If people can't really do both hands, one eye covered, just make it more straightforward for them. Just point to the finger it's moving. Good. Good. Don't want to do math. So visual fields, remember, is getting more traversing through the cerebrum too, where you actually see vision cognitively to the occipital. So it's a mixed bag. We're gonna get to trigeminal now. Does it feel the same both sides? V1 feels like fingers touching you on both sides. Feels like fingers on both sides.
Yes.
We want patients to have very simple understanding, not make it complicated. Does it feel like fingers? For non-physiologic splitting, for functional, does this feel like fingers on both sides?
Yeah.
Good. You might have, well, support feels different. That's non-physiologic. Bite down. Excellent. Master strength, equal muscles. Now we're going to get to cranial nerve 7. Can you show me your teeth? Good. Good. Grimace, equal nasal labial folds. Elevation. Could you close your eyes tight? Resist. I'm going to try to open your eyes up. Resist. Good. Open your eyes up. Can you wrinkle your forehead? Good. Equal furrows. Can you puff up your cheeks? Good. And close your lips tight. Good. Even though 7 does other activities, we're not even checking it. We're really having a very reduced reductive approach. So we get to 7. So we're actually crossing now through the brainstem, all these areas. Now, cranial nerve 8, do you hear these fingers?
Yes. Yes.
Good. I'm going to say a number, tell me what it is.
35.
Good. That's right.
27.
Excellent. So perfect. All right. So we did 8. Now we're going to dip further down into the medullary area. So open up your mouth, open wide, and say ah.
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 Excellent. And that was great. His palate rise midline. You want to make sure the palate rise midline, not the uvula swing, but the palate, the soul palate, the midline raphe, that line in the middle. You want to see each part of the muscle rise equally. We're going to check your gag response and say ah.
Ah.
Good. And actually had a good gag response. So we just 9, 10. Now we're going to get to 11, spinal accessory. Lift up your shoulders. Excellent. Now equal shrug, trapezius. Now I'm going to have you turn your head to the right. And now you're going to actually push your hand into me. So good. Good. Now the other side. Now push your hand into me. Good. Excellent. So good sternocleidomastoid muscles. Now the last part is 12. Stick your tongue out. Move it side to side. Good. Now push your tongue into my hand. Good. Good. And open your mouth open wide. Let your tongue just sit, relax in your mouth. And it looks great. So that's a cranial nerve exam. Everything looks very good. Normal. The normalcy looks good. So thank you for doing this. You look very healthy.